Hi, I'm Jamie Gregor, gastroenterologist here at London Health Sciences Centre. I'm a professor of medicine at Western and at the Schulich School of Western. And I've been a gastroenterologist in practice for almost 30 years. I'm excited today to go over some of this topic for those of you watching. I want to thank the Canadian Digestive Health Foundation and Lupin for giving me this opportunity. I understand that over the year, the Canadian Digestive Health Foundation fields many questions from healthcare providers and healthcare consumers across the country. And it turns out that the microbiome, something that I'm interested in terms of its treatment of functional GI disease and irritable bowel syndrome, is one of the most important questions that's been asked this year. So today what we're going to do is talk about the role the microbiome plays in patients with functional disease, particularly irritable bowel syndrome, and talk a little bit about a novel virtual tool that we've been speaking to physicians about. So to start off today, we're going to introduce the brain, the gut, and the microbiome as an axis and sort of highlight the multifactorial aspects of irritable bowel syndrome. We're going to talk a bit about therapeutic options, everything from lifestyle options right through to pharmacological options. We're going to talk a little bit about digital technologies that are in development to help both the provider and the consumer. So first of all, like with any complicated disease, irritable bowel syndrome is a multifactorial condition. We talk about the role of the gut, the role about the brain in the perceptions of pain and symptoms, and then the various factors that can affect both the gut and the brain in producing such issues. I see patients every day with irritable bowel syndrome, and I talk to them a little bit about the importance of realizing what we think of as the primary pathophysiology. In essence, what usually we talk to patients about is we talk about the exquisite sensitivity of the nerves in the gut, this concept of visceral hypersensitivity to various factors such as noxious stimuli, contraction, and distension. And those nerves in the gut are stimulated primarily by the amount of gas and fluid that's produced in the gut by the combination of what we eat and the bacteria or microbiome that's in our gut. Of course, all of these, this main axis is affected by numerous other things. And we all know that changes in the microbiota, changes in emotional factors and stress, and other issues such as diet can all play a very important role in how all of these systems interact. When we think about the microbiome, we have to tell patients that this isn't some sort of strange thing that's foreign to us. We're born with a microbiome and develop it early on in life, and it sticks with us. The microbiome is an incredibly complicated place. You can see from the diagram on the right, we're really only beginning to map out the various species that live there and put them into categories. We know that the microbiome mass increases as we move down the digestive tract, and as the pH of the gut increases and then comes down a little bit in the colon, we can see that we have an increased number of species which all interact together to produce what we call the microbiome. We really don't have a great understanding of how those changes in the microbiome overall affect us, but we do tend to notice some trends, such as the increase in certain species called firmicutes and a decrease in other species, such as Bacteroides species, that we see in patients with symptomatic functional disease. So at the end of the day, when we talk about the microbiome, it's a very complex interaction. And you can see at the bottom here, we've got a kind of a circle where the microbiome contributes to how our gut feels, and how our gut feels contributes to the microbiome. So what are some of the factors that can affect the microbiome? Well, of course, what we eat is very important. The bacteria in our gut are very potent metabolizers of the food we eat, particularly fermentable carbohydrates and fats. We know that certain hormones and other nerve activation within our gut that can be induced by stress and psychiatric comorbidity can affect the microbiome. And of course, we always have to remember that the microbiome can have similar effects in the opposite direction. There's ongoing research in terms of looking at altered host immunity, in terms of how the body responds to the microbiome, and indeed how the microbiome copes with our actual immune response. At the end of the day, as I said, the byproducts of what's produced by the microbiome, both the gas and fluid produced by fermentation, and also the various toxins that can be produced by that, can cause low-grade active inflammation, and can also alter intestinal physiology in terms of motility, in terms of the secretion of mucus, in terms of intestinal permeability, and also the secretion of various hormones and neural functions. We've got lots of basic science work that goes on, and I think this is just one small example of how the microbiome can affect the gut and indeed behavior. If we look at patients who, quote, are normal or have no actual functional GI disturbance, and we take samples of their microbiome and we put them into a mouse without a microbiome, a germ-free mouse, we can see that there are significantly different changes than if one introduces the microbiome from a patient with irritable bowel syndrome into that same mouse. What we get in when we start looking at the microbiome of patients with irritable bowel syndrome, we see that that can induce in mice accelerated transit time, increases in colonic epithelial permeability, and also induce and increase immune activation. Now, one of the best models we have for the actual induction of changes in the microbiome causing irritable bowel syndrome is probably what we see in a condition called post-infectious irritable bowel syndrome. As a gastroenterologist, this is a very frequent condition. It's actually a condition we kind of like to diagnose because we know the prognosis is good. And patients who have an acute gastroenteritis will, in some cases, can have changes in intestinal function, changes in the microbiome that can go on to lead to changes in motility and irritable bowel syndrome for many months after the infection's actually cleared. Probably one of the saddest, but probably one of the best examples of how infection can cause irritable bowel syndrome was the Washington Health Study. I remember being there just over 20 years ago when Washington had a severe outbreak of E. coli. There was significant illness in the community. And what we saw in patients that suffered that E. coli illness is that long after the illness was cleared, many patients, over a third at 2 years, and about 1 in 7 at 8 years, had ongoing motility symptoms. The risk factors for those are some of the risk factors we often see in irritable bowel syndrome, such as younger age and patients who have more difficult coping skills or more issues with stress. And there was also an association with more severe acute infection. Patients that had more inflammatory damage went on to have more, probably more visceral hypersensitivity and probably some ongoing changes of their microbiome, which made symptoms persist for many years after. So this becomes a novel target now. So we do have lots of ways of counseling and potentially treating patients with irritable bowel syndrome, but the microbiome is becoming an increasingly important target. And making some minor adjustments in the microbiome has been shown to potentially make significant effects, beneficial effects in patients who are very symptomatic from irritable bowel syndrome. So what are the various modifications we can make? Well, dietary modifications are becoming increasingly common. The use of prebiotics we see, the use of probiotics, and finally, the advent of gut-specific minimally absorbed antibiotics has revolutionized the treatment of some patients with irritable bowel syndrome. So whenever we're talking about diet, I think over the last decade, the low FODMAP diet has become the increasingly go-to agent. And today alone in clinic, I counseled at least a dozen patients on the low FODMAP diet using various mechanisms, which we'll talk about later. Now, FODMAPs are what we call fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And what I tend to tell patients is these are carbohydrates that our bodies don't break down or digest particularly well, at least initially. And in doing so, these agents become available for fermentation by the microbiome. And when that fermentation occurs, we get different things occur. We get osmotic overload, which can produce diarrhea. We get bacterial fermentation, which can actually produce excess gas and fluid and cause an increase in water secretion throughout the gut. And we can also get changes in the actual gut flora, which can be referred to as dysbiosis. So what about the FODMAP diet? How do we use it? Well, the FODMAP diet, for something that is a lifestyle modification, actually works fairly quickly in patients. It's been studied, and we'll talk about that in later slides. But one of the things to remember is that the FODMAP diet is usually used fairly intensively early on. It's ideal if we can give patients some good counseling strategies, sometimes in concert with a dietitian. It's ideal if we can use all the technology available, such as the various apps to help patients manage the low FODMAP diet. And then after introducing the low FODMAP diet, we can ask patients to become a little bit more liberal and start introducing some of the higher FODMAP foods incrementally to the point where symptoms are maintained adequately. And ultimately, many patients personalize their FODMAP diets quite nicely and do very well. And any changes, any modest changes that are maintaining the microbiome seem to be associated with ongoing improvements in symptoms. Now, what's the proof? I mean, at the end of the day, we have consensus conferences, we look at various proofs, and there have been a number of trials, 7 good trials, all meta-analyzed with a reasonable number of patients. And although these patients were studied very well, there is a concern, of course, when doing any dietary study, that blinding can be very difficult. But despite that, a low FODMAP diet appears to be very effective. An overall reduction in global symptoms of about 25% has been observed, and really no adverse effects, particularly over the short term. A low FODMAP diet's been compared with controls, with typical diets, and also with a gluten-free diet. And one of the things that I think we have to remind patients is that there is a big overlap between a gluten-free diet and a low FODMAP diet. The difference, however, being that a gluten-free diet is designed to eliminate the protein gluten or gliadin, which causes a direct immune response in the small intestine, whereas a low FODMAP diet, where some of the foods do overlap, is designed to eliminate those fermentable carbohydrates that the microbiome feeds upon to produce the excess gas and fluid that the gut has such a hard time dealing with. And when you put it all together and you look at various consensus conferences, in general, it is recommended that a low FODMAP diet is an evidence-based way of approaching patients, at least over the short to medium term. Now, I've spoken a little bit about the various apps, and this isn't to advertise any one app in particular, although this is the app I use for Monash University. That's Monash University in Melbourne, Australia. They've done extensive research and clinical trials in terms of the low FODMAP diet. They have an app that's updated frequently and not with any ongoing cost to patients. And I find it very effective, and many of my patients do download this app, although many patients use other apps just as effectively that they get from the App Store. The great thing about the low FODMAP diet is not only does it provide excellent teaching around the diet, but it also can be personalized according to country. It has nice, easy to read categories with regards to foods, and pretty much any food you would ever encounter either in a restaurant or in the grocery store is accounted for in various forms. And in those various forms, not only are we told whether we should try to avoid them, eat more of them, eat less of them, but we're also given some idea of what various FODMAPs are elevated. In this case, with avocados, it is sorbitol. Now, what about prebiotics? Well, prebiotics are basically substances, essentially like FODMAPs, that certain bacteria, the microbiome, consume to actually undergo their physiologic processes. One of the most common prebiotics is psyllium. And we do recommend, certain prebiotics, although not every prebiotic is good for everybody. And in fact, certain prebiotics can actually cause increased fermentation in the gut. And so we tend to try to avoid many of the insoluble fibers that are found in certain wheat bran, whole grains, and vegetables. And we tend to focus more on soluble fibers that can sort of hold water and resist fermentation as they go through the gut. And there have been a number of RCTs, and fiber has led to a statistically significant benefit in terms of IBS symptoms. So it should not be overlooked as one of our lifestyle management strategies. And overall recommendations are that insoluble fiber is recommended and that the evidence is pretty good. Now, what about probiotics instead of prebiotics? Well, probiotics are something that patients, again, ask me about every day. As you saw from the our diagram of the microbiome, there are literally millions of different types of bacteria that we could go to. Over the years, many bacteria that people have looked at have been things like lactobacillus, and more recently we see more studies with bifidobacteria. People even use non-bacterial microorganisms such as Saccharomyces to augment the microbiome. Now, it's very difficult to study these, mostly because the formulations are so different. There's different orders of magnitude, from 1 billion to probably 50 billion colony-forming units. There's different ways that these organisms are supported in terms of the prebiotic nature of what's in the formulation and whether or not the formulation has to be refrigerated. There are different, obviously, combinations, some with single probiotics, some with multiple species. And at the end of the day, just like every other trial of irritable bowel syndrome, our standards or our outcome measures are quite variable, and it can make it difficult to bear across studies. But despite that, meta-analyses again are attempted, and there have been a lot with 37 trials and 4,400 patients. And in overall, if you look at these studies, there is a benefit, and with a very reasonable number needed to treat of about 7. So in other words, about 7 patients would have to take probiotics on a regular basis for one to have some benefit. The improvement tends to be obviously symptomatic. Some studies like lactobacillus have been, studies of probiotics such as lactobacillus have perhaps been a little less promising, but there's been other combination probiotic formulations, and some with bifidobacteria containing strains that have shown benefit. And overall, it is generally recommended by consensus groups that it's not unreasonable to try probiotics for the treatment of global IBS symptoms. Now, what about treating the microbiome a little bit more specifically? For many years in patients with excess gas, bloating, and diarrhea, it's not been uncommon at all for gastroenterologists and even general practitioners to go a little off-label and to use various antibiotics such as metronidazole to try to treat patients' symptoms. And many times, without randomized controlled data to that effect, we have seen some benefit. Well, we finally now have easy access to an antibiotic called rifaximin, an antibiotic that every gastroenterologist is familiar with for its effect on the microbiome and in improving symptoms of hepatic encephalopathy. And rifaximin over the last few years has gained quite a bit of popularity after some positive randomized controlled trials in treating the symptoms of irritable bowel syndrome, particularly the non-constipated version. And how rifaximin actually works is it works in the gut. It's minimally absorbed. It targets bacterial DNA-dependent RNA polymerase. It affects the overall production of gas, fluid, and other products such as bacterial toxins. It doesn't sort of seek out one particular bacteria group in particular and eradicate it. So the overall composition of the microbiota remains fairly constant. And the overall effect is probably related to the decrease in toxins and liquid and gas load. So does this work in the real world? Well, here's the clinical trials that have led to its approval. These trials were actually published over a decade ago, although it's only been in the last 4 or 5 years that this product's been available in Canada, and for a few years longer in the United States for this particular indication. The classic way that we run trials with irritable bowel syndrome is to look at the actual stools themselves and actual pain. And there's been an increasing trend to look more at stool consistency than frequency. So in patients with primarily IBS-D in the target series, essentially approximately 1,300 patients over 2 different trials were looked at. Their initial symptoms were assessed in terms of stool consistency using a 5-point scale, not a 7-point scale. So those of you familiar with the Bristol scale might be a little bit taken aback that 7 isn't the watery stool, it's actually 5. And these patients all, of course, had to have IBS related pain to qualify. And patients overall who had these symptoms, to be considered successful, had to have a weekly stool consistency score of less than 4 and at least a 30% decrease in pain for 2 out of the 4 weeks being assessed. I think this is not just from study point of view, but I think it's important as a clinician to be able to explain to your patients what the actual expected benefits are. And even though most patients who experience benefit experience more than a 30% decrease in IBS-related pain, I do think it's important to tell patients that they can't expect to have all of their symptoms completely gone. And of course, in these trials, the difficulty, just like with all the other trials we talked about, is the overall placebo rate. You can see with placebo given regression to the mean and the placebo effect, that the overall benefit is in the order of 36 to 39%, but that it's clearly better with rifaximin on the order of 47% in both trials. Now, when patients get benefit, how long does the benefit last? Well, this was an open label study called Target 3 that looked not only at the persistence of benefit past that 12 weeks that we looked at in Target 1 and Target 2, but more importantly looked at the ability to recapture benefit. And indeed, in this study, they took over 2,400 patients and treated them with rifaximin, and 44% met the full clinical response of 30% improvement in pain and a 50% improvement in stool consistency. And then the patients were followed and for up to 18 weeks for recurrence of symptoms. And the median time was very much just like the trials. About 10 weeks after completed, the average patient started to have some recurrence of their symptoms. In this case, were then retreated in a randomized, blinded, placebo-controlled fashion with, again, almost exactly the same benefit as we saw in the original trials. So in other words, treating a patient with a second course of rifaximin, if required, and again, only if required in approximately 64% of the patients, but if required, is indeed beneficial. So overall, there's been 5 RCTs reported in 4 articles using over 1,800 patients with rifaximin in the non-constipated subtype of IBS. And there is a definite statistical significant benefit in favor of rifaximin with a number needed to treat of 9. Although I think one has to emphasize that the number needed to treat of 9 is that over placebo. And in fact, in clinical experience, you probably have to treat only 2 patients with rifaximin to see 1 with significant benefit. And with this, you can see the overall global consensus is a strong recommendation with moderate level evidence that rifaximin is beneficial in the treatment of non-constipation irritable bowel syndrome. So where does that leave us when we're thinking about the microbiome? Well, first of all, when we see a patient who has irritable bowel syndrome, we want to make a positive diagnosis. And a positive diagnosis is change in frequency, appearance, consistency of stool for at least 3 months over the last 6 months. And of course, patients have to have associated abdominal pain. Now, of course, irritable bowel syndrome isn't the only condition that can produce such symptoms. and we're always have to be on alert to make sure we're not dealing in the rare instance of a case of a malignancy or perhaps slightly more common an inflammatory or truly allergic phenomena. And to do that, we like to get a CBC. We like to get markers of inflammation, a C-reactive protein, and a fecal calprotectin if available. It's nice to rule out celiac disease with a serology, tissue transglutaminase, and total IgA level. And of course, in patients with any significant red flag symptoms or a very significant change in the bowel habit, particularly over the age of 50, sometimes a colonoscopy is indicated. So when we approach a patient with IBS, there's an overlap in many of our treatments. We have our IBS-D patients on the left, our IBS-C patients on the right, and then we have our mixed patients who will come to us. We see them every 3 to 6 months, and when they come to us, sometimes they're more in a diarrhea phase, and sometimes they're more in a constipation phase, and we tend to sort of target treatments during those phases, with the caveat that a patient may change categories at any time and require a slightly different approach. So you can see that microbiome effect. We can treat the microbiome with probiotics. My personal preference is bifidobacteria containing probiotics, and of course rifaximin, which is being increasingly used. The great thing about rifaximin is even though it is really intensive therapy, it has an incredibly good side effect profile because of its non-absorbability and because of its short-term 2-week intervention. In terms of non-microbiome directed therapies, those tend to be directed more at the enteric nervous system. The use of over-the-counter antispasmodics, things such as pinavirium on the muscle side, or buscopan on the nerve side, tricyclics, which have an effect both on visceral hypersensitivity and the autonomic nervous system, and the opioid derived agent elaxadiline in the appropriate patient without a history of significant biliary disease or alcohol use. The elaxadiline can be very helpful for patients with IBS-D. For mixed IBS, tricyclics and antispasmodics. And of course, for patients with IBS-C, I think our treatment paradigm has been revolutionized by the advent of secretory agents such as Constella and or linaclotide or Ibsarella. Of course, all these treatments aren't worth anything if we can't sort of counsel patients properly, recognize the appropriate patient, and come up with the appropriate intervention. And so here are some of the tools that the CDHF is offering that they're everything from trifold handouts to online algorithms that can be attached to EMRs, everything from some basic pathophysiology to burden of disease to make patients feel that they're not alone, to treatment algorithms, and even so far as to look at the various treatments and their overall efficacy and number needed to treat. And then finally, symptom trackers for the patients. I think, when we see patients with irritable bowel syndrome, we're not responding to their symptoms on a day-to-day basis. We're responding to their overall symptoms over a longer period of time, of months, and sometimes patients' memories can fail them a little bit, and having appropriate trackers that can either be written down or through this new IBS app, I think are going to be vital. Because at the end of the day, when we see a patient, they're going to go through phases, and they're going to, at any point in time, they're not necessarily any point in time is not necessarily going to be representative of their whole, the whole cycle of their disease. And by being able to track their symptoms, follow their symptoms over time, either prospectively or retrospectively, and find out which things in their lives, which lifestyle factors, and which interventions have actually worked, only then can we really come up with strategies to help our patients. So I hope at the end of the day, I've talked a little bit about dysbiosis. I know it's a confusing topic. I get a little bit confused myself, and every time I read something, there are slight changes in the way I think about it. But certainly dysbiosis is not going anywhere. I think effects on the microbiome and trying to treat IBS through treating the microbiome is going to become increasingly important. We know that from post-infectious irritable bowel syndrome. We know that through our study of the brain-gut axis. And most importantly, we know it from the clinical studies, which have shown benefits of targeting the microbiome and in the improvement of the symptoms of our patients with functional GI disease. Thank you very much.